Okay,
Can y'all
go.
see?
Everybody's there? Okay. Channing is left us or?
She's in
Oh, she's right here.
I'm right here.
In the background. Okay. All right. I'm going to have Kristen take the first approach. Do you see the image?
Yes.
Can you see it clearly enough? I can move the computer closer.
I have it pulled up over here too.
Okay.
Yep.
Oh, we just lost those.
Oh no.
Oh, she came back.
Okay. Anything bigger?
Yeah, it looks like
Okay. What do you see there? What do you think it is?
So it looks like he has the red papules and box scarring with it.
Mm-hmm.
So I would say PDL, several treatments of the PDL, and then doing a couple of Infinity treatments as well.
Sounds excellent. And what do you tell him about downtime? And what do you tell him about if it's him? Maybe you think might be God. Don't know. Think of that. What do you say about like expectations and what we want to achieve and why you're doing anything to PDL just to make it beautiful, or you have another intent? So give me a little bit about your actual conversation with this patient.
Mm-hmm. I would tell them that we would treat the pigment within the scars first and tell them that they will turn a blueberry color. He'll experience redness and swelling with it for a good week. Again, he'd need several treatments to reduce the pigment.
Give him a ballpark. How many treatments you think?
Maybe like four to five treatments with PDL.
I would say 2 to 3 is more likely,
Okay.
because many times he doesn't seem to have any current inflammatory acne on the face anymore. There seems all to be these erythematous depressed papules that have occurred and left just like some long-lasting inflammation behind, and it's at risk of creating like very deep dimples. And this might have only been inflammatory acne that caused it. It might not even have been cysts, but he could have had cysts because well, we don't know actually. Even inflammatory acne, even acne that we call moderate, can cause scarring, and that has been shown more recently, conclusively when patients were followed photographically and they never really actually even had cystic acne and still created scars on their face. And so I'm going to have to say about 2 to 3 treatments should actually take care of it if you achieve the blueberry muffin look. And that's kind of a very, very important parameter that if you go too lightly and if you think you can crank this out by simply using settings that you'd otherwise use to treat rosacea, you're protracting the treatment just kind of artificially, and you probably never really get to results that you want to get to. So I know some patients will say, but I can't really afford downtime. Then I'm going to have to say maybe that's not the right treatment for them. And although I'm strongly going to encourage for medical reasons to actually start treatment in this particular state, because I'm very worried about more scars on the face with this kind of look, with this prolonged inflammation. So I think you want to make sure that you explain that it's really bad look. Blueberry muffin is my go-to phrase. And that you would want to kind of in your own time frame, you want to achieve the treatment hopefully in 2 sessions. They can be 4 weeks apart, and patients will have a hard time sometimes scheduling it, because when I say blueberry muffin, they expect the worst, and it's really what they look like. Really bad and very difficult to cover. By probably a week out, it's okay with makeup because it has faded down a little bit, but this kind of purple color can stay for up to 2 weeks until it has faded. And so very important that patients really get that clue. So before you speak about the treatment, mention blueberry muffin first, because that sticks in their head. And then only then later mention some redness, because they need to hear the purple color first. Okay, and then Kristen, you had said you would follow up with Infinity. And okay, what are sort of like your kind of, what is your mindset when you think about Infinity? What needs to be there? You mentioned the box scars need to be there, and I think you'd also implied to say it would be nice if the skin wasn't quite as inflamed when we use Infinity, because that's not a good idea if we were to Infinity into this kind of really inflamed state, and I think we can create potentially more acne. But what other considerations do you have when you're talking to somebody who has recently had some acne, probably this is within the last 6 months, that maybe 6 to 12 months, what other considerations do you have? How do you counsel the patient?
Well, I would say that there's always a chance of the post-inflammatory hyperpigmentation, so we could pre-treat too with the advanced brightening cream. There's always a chance of a breakout occurring because of the response from the Infinity.
Okay, so I think in this kind of patient, I'm going to have, we're off. In this kind of patient, I think I would say not only that there's a chance they will flare with acne, I think this is rather likely that this person who recently had acne, is probably going to have an acne flare when we're pulling out the Infinity, and that this person either can already be treated with like a 1 month course of doxycycline starting on the day of the treatment, or calls the next day if they feel they're getting an acne flare underneath. And those patients usually feel it, they feel like something is really erupting, and they should be counseled to call the office definitely if that is something that they're feeling, because we don't always have to prophylactically think that they're definitely flaring with acne, but it's rather likely that this person is going to be flaring with some acne, and usually can be capped with just a week course of doxycycline or maybe minocycline if it's summertime and they otherwise want to be outdoors. Okay, so if in terms of Infinity, what are you expecting to see in kind of this area? So let's say the best result would be that the pulse dye laser does not allow any of those red papules to actually stay depressed, and that it builds up all of the collagen underneath again after just, let's say, my 2 treatments that I'm anticipating. When you are counseling about Infinity, you want to be, let's say, clear about what we're trying to achieve. So it's also my gut feel to say that this person will probably need Infinity, but I'm not 100% sure about that, because this person may say, if I no longer have any color contrast and everything looks smooth and fine, and then we just see these few shallow box scars here over the malar eminence, maybe that's already kind of a nice result. Maybe that's something that doesn't necessarily need to be followed up with repair deep down. But maybe, yes, depending on how far the person wants to go. And so I think this person might have other options available. Again, I would have counseled the same way, that this is the most likely route. But if the color contrast disappears, it's possible to maybe just do something a bit more superficial in order to actually get the skin surface in these fairly shallow box scars to, at least for me, here they look shallow, to improve. And then what other treatment options might you have?
The picosecond laser for acne scars.
Okay. Any other modalities that you can think about?
Well, they're 15 and 40, but I think you'd still have downtime to help even out the texture.
Yes, I agree. There would be still some more downtime, and most likely some transient hyperpigmentation for this patient. What other options do we have? Anybody else? Wow.
Right?
Well, I wasn't going to say pixel, but
Yeah.
if they're very sporadic and it's not really full, and just say like a few on 1 or 2 on the cheeks, would you just consider fillers with you instead?
That's
Instead of
also a
doing full
possibility.
Face area.
Yeah, because I mean, you can technically do a little bit of a local pixel also. You have to really feather it out and reduce the number of stacks. But I think this is this might be a candidate for pixel treatment as well, because it stays pretty superficial. The 1540 might go a little bit deeper than we want, but this might give the patient really, really good results overall, because it reaches into the depth of the scars at least a little bit, remodels, stimulates a bit more collagen. Filler is always a good option if otherwise the face is fairly clear. All of these red dots are now in even texture with the skin. Just a little bit of filler underneath is a great option for this person. So here it's just everything is so striking and everything is unruly looking because of this persistent inflammation. And it's not so much at this point of time that there are texture changes that we can be sure that are going to be permanent. And so our effort needs to be, when we see somebody like this, as long as there's not really active acne or if the active acne is otherwise already started to be brought under control, so he has seen the dermatologist, that he's on a good regimen, and his acne is starting to subside, run after these erythematous depressed papules, make them go away before a deep scar occurs, because it's very, very likely that that is the case. And because I feel strongly about that, this is the pulse dye laser treatment for that. We do submit to insurance, and we do treat patients up to a skin type 4. That means, skin type 4 African American, kind of a lighter Asian. I have still some reservations with anybody Indian. There's just too much of that unpredictable pigment there that I just don't know how to manage that. And so those patients are at a little bit of a loss, but all the others can be treated. If anybody else has a remarkable idea what to do with our Indian patients, I'm open to that. Because they oftentimes need it the most, really, also, right? Okay.
Maybe so.
PicoSure? Yeah, I mean, it can be used, but it doesn't stop the inflammation. It doesn't. It's not an anti-inflammatory like the pulse dye laser, because the pulse dye laser snaps the blood vessels closed, so the cytokines can't patrol anymore. So that stops all of the inflammation right at once, which is a nice physical interruption to this whole cascade. And Nd:YAG, I don't think works as well for that. I don't think that it's my go-to anti-inflammatory laser. Right? Okay, good. Any input about this particular patient that we just lost again?
What settings would you like to use for him?
Okay, so I would like to go, very important, I would like to go about the size of these red depressed papules. So here it's probably a 5 millimeter spot size. I'm gonna go in somebody who's fair skinned, I'm gonna go fairly aggressive, probably 1.5 milliseconds, if I can get away with it, maybe 3 milliseconds, and more likely than not, I'm gonna start out at about 10 joule. If this patient was, let's say, not light Asian, but African American in skin type 4, I think I might go very likely down to 8 joule, and definitely not more than 3 milliseconds. And I might turn down the DCD to 1. Our default is DCD 2, but I might turn it down to 1 in order not to have the cryogen induce more post-inflammatory change than I am ready for. And in a fair skin individual, I will leave the DCD at 2 so the cooling can be appropriate. Again, you would have to play between 3 milliseconds and 1.5. If 1.5 is just too much crunch, then it's not necessary. But you do need to achieve a purple color. Without purple color, you're really not doing enough. On African American skin, this purple color looks a little bit different. It's not as dark looking. So even if at 8 millimeters you feel like, okay, there's a definite color change, you can stick with that.
And for skin type 1 and 2, you would do the 3MS and still 10 joules, or?
Probably. If I don't see enough, I might go to 11. But if I don't see enough, I go to 12. But 10 is probably my starting point.
Is it indicative if you get the result with the first treatment, purple at 10, does that mean next time you want to start off a little higher or not necessarily?
Say that again.
But like your first treatment, you get the purple at 10 joules. Now I'm coming back in for my second. Do I start them off exactly at 10 or do I try them at 11?
Why do you need to go up?
That's what I'm asking.
So if you, most of the time, you get to resolve, each one of those spots. Oh no, that's PDT. No, I don't know. Sorry, wrong picture.
True.
Oh, maybe not. I don't know what it was. But in any event, so most of the time you do actually get the resolution of several of those red bumps already if you get to the purple after one treatment. And then you just hunt after those that haven't responded. It's not like that they are all much lighter in color. That can be an occasional finding. If they're lighter in color and they're coming around for the second treatment, then you can go up a little bit because you don't have as many blood vessels underneath that you can target. If there are just some that are left over that didn't respond to the first and they and you're trying the same settings as before and it just turns the same purple, you need to stick with that. You can't just assume this wasn't enough. It just might need that second impact, but it does not necessarily need a higher power, higher energy level in order to achieve results. Okay? Sorry that we lost the picture here. Can we bring him back somehow? I don't know. Where is he? I don't know. I all of a sudden went into another person.
A little bit off subject for angiofibroma.
Difficult to treat.
I know.
Don't try to treat angiofibroma. Always say, I don't know that I'll ever make it go away. They can go back. So angiofibromas are comprised of kind of very fibrotic fibroma, connective tissue. So your second of the layer of the skin is kind of very firm, dense. That's why there are also like these firm papules on the sides of the nose. And then there's some blood vessels trapped within that. And what you can target with the pulsed dye laser is the blood vessel. What you cannot target and completely destroy is the fibrotic tissue. And so when you are targeting angiofibromas, probably the best solution, but I don't know if it gives you 100% results, is to shave it down so it's no longer elevated, and then maybe, let's say, about 6 weeks later, pulsed dye laser to the base of that. Maybe you're lucky. I don't think that anybody's ever really in the mood to pay so much for an angiofibroma, because now it becomes costly. $130 for the shave removal, another $105 for the hit of the base, and with the non-guarantee that they're going away. So in other words, you have to say there's a chance that although it's shaved flush, and although you're really improving that whatever is left over with the pulsed dye laser, and even improving the scar, which is kind of a flat scar that hardly anybody ever sees, you still have a chance that the angiofibroma wants to come back. And so I'm never so optimistic, and then finding somebody who's willing to pay how much? $235 for that? Not sure that it's easy. There are angiofibromas that are just pink and ever so barely elevated, and you feel like, oh my god, that should respond like a cherry angioma. And no, that is not the case. They do not respond like cherry angiomas. They do need a lot of effort to be destroyed. If they're on the very, very tip of the nose, it's always like a little bit tricky not to depress the tip of the nose, the sides of the nose on the ala. You can usually get away with like multiple treatments of the pulsed dye laser. But if you're trying to do it all with pulsed dye laser, and I've tried that many times before, right? Because I really don't want to scar anybody, because when somebody hears, oh, a scar on the nose, that's bad, right? I don't know that I can always be successful.
So do you usually would recommend to see the provider and maybe consult shaving it
So
and then
that
laser?
So that would be a good combination approach. But again, I think what most of the time where they're disturbed, because it's the nose, when they hear the word scar, and we have to disclose the word scar right up front when we shave something off, although the scar is basically hidden in the cut surface, but we still have to say it. So if they hear it already before, and they might hear, okay, and then we laser afterwards, because PDL would also treat a scar very nicely, and might not even allow a scar to form in the way that it would normally form. You know, they might already be at ease and say, oh yeah, I know, and then it's easy to kind of get them through. But sometimes I find when they see the physician first,
See, that's the problem though, because they will refer to come back to see the esthetician for the PDL, but it never gets anything. So I'm like, am I not using the correct settings, or is it? Okay.
No, it's just this fibrotic tissue that you can really not destroy with the pulsed dye laser. And you know, some people would say, okay, we'll try at least if we can get the red color out. The skin color bump would not bother me as much.
Okay. What settings do you like for that?
For the pulsed dye laser?
For the angiofibroma.
Yeah, I would probably use the same settings as for a cherry angioma.
Okay.
Very, very same. But again, I'm not always very successful, and it does take a lot of doing in angiofibromas.
Okay. Okay. Yeah, that's what I've been using, but it's not turning the color. So I'm like, maybe am I not going
Then you're going
strong
to
enough?
have to go stronger.
So, but you still want that bruising?
Yes.
Oh,
Without the bruise, you're probably not going to reach the blood vessels there.
okay.
Yep. All right. Any other questions about angiofibromas?
I'll show you.
There's a condition, a genetic condition, where we see tons of angiofibromas, so that they can be isolated and kind of just occur on the rim of the nose, including the tip or the dorsal nose, and they can be part of a genetic syndrome that looks like acne. And that's a pitfall. And so you have to kind of sometimes put a little caution on. So if you see somebody, let's say a 12, 13-year-old, and all of a sudden everything looks like angiofibromas on the sides, like the medial cheeks, think this might not be acne. And maybe this patient kind of booked themselves for a facial or who knows for what, you know, sometimes be on the lookout. If something doesn't look like acne, it could be a pitfall and it might not be acne. And those patients also have angiofibromas around their nail folds. They're usually painful, sometimes really annoying. So on the fingernails, sometimes on the toenails. And so I've been trying to treat those with PDL also. That's the only thing that we can do in those locations. There we don't tend to cut because we don't want a scar around the nail fold because that can cause all sorts of other problems. And it's really, really very difficult to treat. Very. Not an easy condition to treat. Okay, and I stay pretty aggressive with the PDL there. That's the way to go.
Thank you.
Okay? Good. I think this concludes our session today.
We have no time, right?
Okay.
No, I don't think